Hello and welcome to the Rural Doctors Programme. I'm Jerry Gannon. Thanks for your company this evening. Our programme tonight focuses on mental health along with drug and alcohol use and looks at the relationships between these areas of health. The correlations between these two areas mean that in many circumstances and for many patients, the separation and the potential divergence of clinical pathways it represents is, at the least, a little bit arbitrary. With this in mind, we'll be discussing some aspects of mental illness and drug and alcohol use in isolation, but we'll also try to delve right into the assessment, diagnosis and care of patients suffering from both mental illness and drug or alcohol dependence. We'll also talk with Dr. Simon Byrne, consultant psychiatrist at Sir Charles Gardner Hospital, about the presentation, assessment and diagnosis of mania. And later we'll look at drug and alcohol use in pregnancy, including some recent research that indicates the level of advice and investigation by all health professionals into potential drug and alcohol use in pregnancy, and it's not what it could be. But before we leap into the programme, I'd like to make a few announcements about upcoming Rural Health West events and programmes. Firstly, a reminder that this year's annual conference and trade exhibition returns to Intercontinental Burswood on the 26th and 27th of April. The theme this year is Making Rural Communities Work in Boom or Bust, and will feature eminent keynote speaker, the Honourable Dr. Barry Jones. By now you should have received a registration brochure for the conference. If not, then please call Rural Health West on 08 6389 4511. The Rural Family Medical Network has also organised a great range of family and support activities over the weekend of the conference, and they've asked that all reservations be in well in advance to ensure that no one misses out. Now, if you'd like more information about the Rural Family Medical Network's programme of events for the weekend of the conference, you should contact Wendy Williams at Rural Health West. There's also one place left for our course in Acute Crisis Resource Management on the 28th of April, to be held in Perth within the simulated hospital environment of UWA's Clinical Training and Education Centre. If you're interested, then please contact us here at Rural Health West. Now let me introduce our panel for this evening's programme. Dr. Olga Ward will again chair the discussion. Welcome, Olga.
Thanks, Jerry.
And Associate Professor Moira Sim joins us. She's a GP and specialist drug and alcohol physician, and she coordinates the postgraduate medicine at Edith Cowan University. Welcome back, Moira.
Hi, Jerry.
Dr. Leighton Chadwick is a psychiatrist at Greylands Hospital and also works in private practice in Midlands. Welcome, Leighton.
Thank you, Jerry.
Now, before we begin, a reminder that this is an interactive programme, so if you have any questions for Olga, Moira or Leighton, you can have your say at any time by giving us a call on 0800 673 277 or 08 9229 5241. So, Olga, mental health, big issue, lots of people suffering from it in our community.
Very big issue, Jerry, and indeed a great part of general practice. And in fact, in general practice, I think our biggest problem is that mental health problems don't occur in isolation. And so we'll get a patient who's diabetic and depressed because of his marriage breakup and smoking too heavily and drinking too much, and comes in because he's mighty depressed. Where do you start with patients like that?
Well, I think certainly in a patient with complex problems, usually involving multiple systems, I think the general practitioner certainly has to be the hub of all treatment, really. I mean, I suppose as a psychiatrist I'm often involved in these sorts of situations, but don't see myself as really being the person that is the key to all of it. I think the general practitioner obviously would have a good grasp of this person's problems, generally their place in the community, how they may be affected functionally, and is a good referral source to a psychiatrist and a source of great information, and it makes it very easy to start if you get the right information. Obviously, as a psychiatrist coming in there, you very much have to be playing your own part and making a very thorough assessment of your own, perhaps even with more responsibility given the complex sort of situation that such a patient may be in.
So it looks like it's up to you and me, Moira, but say if we're trying to case conference something or get something happening for the patient that involves the GP and the psychiatrist and perhaps one or two other members of the mental health team, how do you instigate that, Moira?
I think I mean, those things are a bit tricky to kind of set up because of the number of people that you need to try and, you know, get together at the same time, etc. So I actually often don't start off with, certainly as far as the Medicare case conferencing items, not that easy to use, I personally find, because of the needing to get people together at the same time. But I think the thing about general practice is that, you know, as Leighton says, we know people, we know them over a period of time, and you don't have to deal with everything all at once, even though, you know, there sometimes is that sense of, oh my God, I have to, because the thing for GPs is that we're the only ones who feel responsible for everything, because we deal with everything. So with case conferencing, I think, you know, you kind of have to pick up the phone to speak to a person who's helpful, get involved other people as you can, but I don't think you can actually try and easily set it up unless you've got someone who can organise it for you.
So, Leighton, what's the really useful information that a GP could give you, say in a referring letter or a call?
Yeah, certainly, obviously, the past psychiatric history as known to the GP is very important. But I suppose what's more important to me really is a sense of how severe are the symptoms and over what time span they've been developing. Often that does take a lot of time to actually really get a good grasp of that. Early on. People are often, if they come to you after a long period of time with their symptoms, they're often a bit vague exactly when things started, what they've tried before, what treatments they've had. Yet for psychiatrists, they're crucial in actually planning your treatment and your management from there on. So particularly information about severity of symptoms, the duration and past psychiatric history is very, very important. So if anything, perhaps more information about that sort of thing for a psychiatrist, obviously it makes sense. Look, obviously, if there are important medical problems that are very much comorbid or correlated, we'd need to know a bit about them. Most of us, particularly if I work in private practice, work in isolation a little bit, and we don't really have a lot of good medical knowledge. We need to be reassured, perhaps, about some of those things, I think, from time to time.
So if we'd, say, tried 2 or 3 antidepressants and weren't getting anywhere with a patient, that would be useful for you? Is
to know exactly what they have been and for how long and what doses. And often you ask the patient, they can't remember what the medication was or what the dose was or for how long they even took it for. So it does make it a little bit tricky. And sometimes, of course, when time is poor, you just, you know, you don't make the phone call. You make a guess, talk to the patient. You maybe get the big MIMS out and show them a few pictures and ask them if that looks like it. But, I mean, sometimes you're not always on the mark. And I think it's really important if you had someone who's complex and not responding, particularly if it's to medications, and obviously that's not the only mode of treatment, but it's really important to know that medication history and response or lack of it.
What about the kind of social background of the patient and things like their drug and alcohol use? How does that come into it? A lot? Not a lot?
People often do self-medicate, you know, their symptoms. I mean, you know, alcohol and drug use is a way of coping. So it certainly is part of the history that you have to take, and people are often a bit sensitive about it. So you know, it's asking it in a routine way, but very, very important, because the two are, I think, it's fairly rare for someone to have one disorder without the other. You know, some use of the other.
Well, I guess medication's all very well, and the drug and alcohol intake is definitely going to happen. And we certainly prescribe our fair share of antidepressants. What would you say is the most effective way of actually supporting depressed patients?
There's probably no one effective way, is there, really? I mean, there are as many ways of approaching it as there are patients and the problems that they present with. I think, obviously, you know, it sounds pretty basic, but the history and the mental state examination coming to some sort of diagnostic formulation and planning management from there. So it really depends on what actually are the symptoms or the problems that are troubling that patient there and then, or over a period of time leading up to the consultation. Certainly, though, there's no substitute for effective engagement with the patient and having them feel that they can be comfortable with you. That there can be generally a relaxed and friendly demeanour without really being a friendship, of course, although that may be a barrier, of course, in some rural areas or a complication, perhaps. And certainly establishing that effective engagement, so an empathic approach, developing an environment that the patient feels comfortable in seeing you, can talk to you about anything at all that troubles them. That's certainly the most effective way at an interpersonal level. And look, most of us, I think, as doctors, develop techniques based on our personality and our clinical experience that allows us to do that. I think that's probably the key to everything. Everything else flows from there.
And I think the other thing about the rural setting is you can't underestimate the effect of the rural community and how the rural community kind of organises itself, around supporting that person. I know that, sometimes I've done rural locums in nearby towns, and some of those patients still come to see me from time to time, particularly when they're a bit under-doctored, as often is the case. And there's a really big difference in terms of what happens, I think, when I look at my city patients. There's just this sense of, if somebody's going to come all the way to town to do things, or I've had a woman who's, been feeling suicidal, and the whole, they set it up so they had this 24-hour almost roster around her, which is really unusual to see in a city setting.
Mm. So I guess because there aren't the official mental health services on deck, the people in the town take it upon themselves, or the people who are in the surrounding farms take it upon themselves to do the suicide watching, or the mood watching, or, no, you're turning into a super bitch, this medication isn't working.
And they also do it at a much earlier setting, long before you start talking about the suicidal, etc. You're probably familiar with some of the programs that aim to try and work on increasing mental health in rural communities, doing things that actually get community spirit, going, where people work together. And one of the protective factors in feeling good and not getting depressed is actually a sense of community, a sense of purpose, having goals, those sorts of things. Mm. So I don't think you can underestimate any of those sorts of programs.
Yeah, certainly social integration and social support are crucial. I mean, they're probably, it's often hard to measure, but they're probably as crucial, as important as any other modality of treatment, whether it be individual psychotherapy or optimal medication. I mean, certainly social support. And of course, that often is something that you find lacking in metropolitan areas, of course, where you don't have that sense of community. And in fact, often sometimes people don't even have that sense of family. And it can be very, very difficult. And in fact, it leads to hospitalisation, where it may not be necessary if there was a bit more support out in the community. Yeah.
I was just thinking while you were talking about that, Leighton, particularly in a country area, when patients are discharged from an inpatient psychiatric facility back into a rural community, how are the arrangements made, say, from the mental health facility, like from Greylands, back out to the GP?
Often made very poorly, unfortunately. Yeah. Probably due to a lot of systemic problems, really, with the pressure of beds at inpatient facilities. It comes to a Friday and there's 14 people coming from the country and there's no beds, and so discharges are made there and then without any prior planning. Unfortunately, that is the norm rather than the exception. I mean, there's a lot of work been going on at the moment at Greylands, for instance, to try and improve that, and we're having a lot of feedback from rural mental health services. But unfortunately, discharge planning is fairly poor across the board. Some places do better than others, but it is poor. And certainly it is very, very crucial, particularly that first week or two post-discharge. That's a period of time when patients who are at risk of suicide are at greatest risk. It's where people run out of medication and don't know what to do, and things can deteriorate very, very quickly from that point of view.
Yeah, I think that's our greatest fear. The patient kind of turns up, you don't realise they've been discharged, they've had 5 days' worth of medication. The first appointment they can get with you is in 8 days' time, or, they get round to asking in 5 days.
At least improved liaison with the local mental health service is something we're trying to achieve at Greylands through teleconferencing and that sort of thing. But I think what we're trying to press on the registrars and junior medical officers is the importance, particularly because it's their role most of the time, to contact the local GP or the referring GP. Unfortunately, it's just not done on many occasions.
Yeah. And I think it's that thing about, registrars actually understanding the breadth of what GPs really do. Mm-hmm. So that early exposure to general practice is really crucial, and getting the, psychiatrists who actually understand that, getting that message across.
Yeah. Mm. So some of the medications the patients do come back with are quite confusing, and some of the doses are absolutely gobsmackingly enormous. Mm. What happens when you're escalating doses of antidepressants?
Yes, well, look, as psychiatrists we get comfortable with often using higher doses, but with the right rationale. You'd want to be seeing at least some suggestion of treatment response with each dosage increase, and you don't want to be overwhelming the patient with side effects or any other evidence of, if you like, drug toxicity. But I think higher doses are something you grow comfortable with, really, I suppose, with good clinical experience. I could see how someone being discharged on a massive amount of an antidepressant or any other medication would find that quite disconcerting. And I think that's where feedback is crucial, because if you can actually reassure the people that might take over care that this is quite okay for this patient and it's been monitored and it's seen to be therapeutic, then you can go a long way to easing a lot of those concerns. The other issue we have sometimes is people being discharged on non-PBS items and they roll up in the country and no one can prescribe them. The mental health service is remote or inaccessible, and that's a real problem. So we need to be more liaison, much more communication with the GPs.
We have a call on the line. That'll be Dr. Chapman. Is that Bernie Chapman? That'll come through in a second. We hear bleeping noises.
He's not there yet.
He's not there yet? He will reappear. In the meantime, Leighton, could you also just comment on mood stabilisers, which I think are, again, something that we see increasingly used. Are they something that maybe GPs should be starting for particularly their depressed patients?
Well, not so much for a unipolar depression, I would have thought, and look, if there's any suggestion of bipolarity, which is obviously often underdiagnosed and often diagnosed very late in the course of the illness, then I think a GP could certainly commence mood stabilisers. There are some few baseline investigations, for instance, with lithium carbonate and sodium valproate. But generally speaking, we're using them at dosages and serum levels that aren't usually approximating those that are used in epilepsy, for instance, because most of them are anti-epileptics if you consider three of the commoner ones excluding lithium. So I think GPs can. The big
and you just run them at a much lower level?
Well, the big issue there is diagnosis. I mean, I think people are more sensitive to the diagnosis of the sort of what we call the soft bipolar disorders, the bipolar 2s, who have mild hypomanic symptoms, but often only present with a depression. Then you can institute them.
Bernard Chapman is on the line.
Oh, good evening, Olga, Moira and Leighton.
Hi.
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 I've got two questions. The first one is for Leighton. If you could please make some comment on combining antidepressants, what are good combinations and what are bad and dangerous combinations? And my second question is to Moira, who may or may not choose to answer this question. When patients come into the emergency department off their face, is there any easy way to know what they might have ingested? When I'm off their face, I mean they've obviously taken something. Is there any easy way to know what drug might have actually caused the particular presentation? Are there any good indicators? If you could have a chew at that, I'd appreciate it. I'll hang up and listen to your answer now.
Thanks. Shall I go first?
Yes.
Well, there actually is no good evidence at all that combining antidepressants is any more effective than using single antidepressants. Although combining antidepressants is done quite commonly in psychiatric practice, it's something that perhaps smacks of desperation on many occasions, but nonetheless, in selected patients with very, very treatment-resistant conditions, you are often looking at just eking out that extra 5 or 10% of clinical improvement. Common combinations we use are venlafaxine with mirtazapine, an SSRI of any type with reboxetine, thereby getting an SSRI, a serotonin noradrenaline boost. I suppose in some ways similar to using venlafaxine, but with a bit more flexibility. They're common ones that we use. I have seen people use 2 SSRIs and various other combinations, but again, there's absolutely no evidence at all to suggest any increased clinical effectiveness across populations. But in selected patients, yes, there may well be, if your rationale is good and they're monitored well, then there may well be some patients that you would consider combining antidepressants. I don't make it a general rule of mine, although saying that I have probably 2 or 3 people that are on high-dose combination antidepressants. People with very, very severe treatment-resistant depression who've had multiple admissions to hospital and have often been very suicidal.
Moira.
Can I make one comment on that one? I don't know if people are familiar with the WA Psychotherapeutic Drugs Committee publication that's available on the Health Department's website. I can let you know because they actually talk about the combinations and particularly which combinations to avoid and why. Or, well, not so much about why, but, which combinations to avoid. And it's really nicely summarised and it's reviewed regularly. So I can give you that
to the website.
Of course.
Yep. In terms of how you tell, what people are on, the short answer is you really can't. The long answer is that, look, there are some indications, obviously. If someone's high, agitated, then they're obviously on something that's more likely to be a stimulant. And someone who's more sedated is more likely to be on a depressant drug. But the reality is the majority of drugs are used in a polydrug way. And most people who come in are on a mixture of stimulants and depressants. If you talk to the people who deal with this a great deal, so for instance, you know, I have a lot of contact with the people at Charlie's who deal with the people coming in very agitated and ED. They don't jump to conclusions. They say, you know, you treat the person as they are. If they're agitated, you calm them down, you use Valium, you know, whatever it takes. And then they do the toxicology. You know, they work out what it is after.
Can I just ask you, Olga, particularly a question as we go to the next segment? In America, almost everybody's on therapy. If you're not, you're mad.
Yep.
Here in this macho Australian society, have you found difficulty in actually getting men in particular to see psychiatrists?
I think that's a perpetual problem. I don't know whether it's just to do with the, you know, I don't have a problem attitude, or whether it's just a doctor underdiagnosing problem, and I think it's probably a combination.
Is it more prevalent in the country than it is in the city?
I think at the moment it's less prevalent. I think that at the moment, certainly what I'm seeing is a lot of farmers who really are starting to get quite depressed, and the thing that I'm finding scary, the wives are saying, we've had enough, which is usually when the blokes are actually willing to say, okay, now we really are at the bottom of the barrel, now we are drought-stricken, now we really need help. And they are actually realising that, you know, I could use a mental health service right here, right now.
So there's no, is there a stigma still attached to seeking mental health, Moira?
Yes, and on top of that, I think, you know, it's made worse by the fact that insurance companies, for instance, can reject you on the basis of having had a history of depression. You know, people worry about those things.
Indeed. Well, thank you for that. We'll be back to this discussion in a while. Well, while clinical mania is not an overly prevalent condition, it can be a difficult situation, as often patients are not feeling unwell. Quite the opposite, in fact. Many cases, manic patients enjoy their highs and can be reluctant to accept advice, see the need for intervention, or adhere to treatments. Dr. Simon Byrne is an emergency psychiatrist at Sir Charles Gardner Hospital. We asked his advice about assessment, diagnosis and avenues for treatment of a manic patient.
There are probably three more or less overlapping ways in which somebody with a manic syndrome might present. The first is the person who has become progressively overactive and overexcited with ambitious projects such as business projects or projects to benefit the world in some way, or projects for personal, spiritual self-development in a very excited manner. And at first people around them might just take it as, well, he's in a good space or in a good mood. But when it goes on for day after day after day, people start to become concerned, and especially, very especially, when the person has a markedly decreased need for sleep. Once a manic episode is really set in, a person's likely to be sleeping 2 or 3 hours a night and still have a huge amount of energy. They'll get up and charge around, ready for action, or even no sleep at all. And while any person perhaps might do that for one night, people actually have to be unwell to do it for days on end.
I'm not there going, you know, had 1 hour sleep tonight or 2 hours sleep tonight.
Has it been like that sometimes, though? Maybe just a couple of hours and then you're up and away?
Yeah, sometimes.
And these are big projects, are they, Simon? They're like big financial transactions?
They are. It's offshore, some overseas, and which means that the time differences.
Okay.
I've got to be.
The second kind of presentation is when the person has become frankly psychotic with obvious delusions, like beliefs that they have special powers, or that they can read other people's minds, or they're in special communication with God, or they're going to be the next multi-billionaire when it's not based on any credible foundation. And usually those sort of statements become pretty evident to other people. The third kind of presentation is where the person engages in some bizarre behaviour, like confronting strangers with bizarre questions, or appearing in public naked, or some other dramatic behaviour which usually comes to the attention of the police, and the police will then usually identify pretty quickly that the person's probably mentally unwell and take them to the doctor some kind of assessment. Occasionally the person who presents frankly psychotic may in fact actually have a schizophrenic rather than a bipolar illness and are presenting in an aroused and overactive state. In practical terms, it doesn't matter in the acute setting because the management will be very similar. More important are the other differential diagnoses, one of which is alcohol or drug intoxication, especially these days with amphetamine and methamphetamine, which can produce pictures very, very similar to a manic state and can be expected, generally speaking, to wear off as the intoxication wears off. And the other, of course, area to never neglect is the possibility that the person actually has a delirium due to some other medical illness. Classic, of course, is the UTI in the elderly, but very, very rarely there'll be some fulminant condition such as a viral encephalitis, which is presenting with this apparent behavioural and mental change. So there's always a need to think, are there any signs here that the person is disoriented or confused or with fluctuating conscious state? Are they febrile? Are there any physical signs? Should we do some blood tests? The person who's manic very often won't perceive the need for treatment unless they've had the disorder for some years and they've developed some insight into the condition. From their point of view, the patient's point of view, he or she feels fine. In fact, they never felt better. So the question is really, what are the hazards of the person not being treated? And those hazards are generally not the ones of danger to self or others in the narrow sense. A manic person generally is not antagonistic to other people, and generally speaking, they're not suicidal either. They're enjoying life. They're making the most of things. They're much more to do with what we call the risks to reputation. Manic people will drastically overspend and borrow money or spend money that they don't have, or buy things which they don't remotely need, like very expensive cars or boats, or enter into contracts which are really not very sensible at all in the long run. Because of the over-energetic, highly charged state, people will often feel very sexually excited, and they'll get into new relationships or get into casual relationships even though they might be in a more permanent relationship. Or there's the more flagrant, obvious disinhibited behaviours, the appearing in public naked or talking to friends or business associates in grandiose or bizarre ways that make people doubt their sanity. And there's a specific provision in the Mental Health Act saying that one of the grounds for detention is risk to reputation. The tricky thing for the GP in that situation is to decide, well, what are my responsibilities here? When do I need to be putting pressure on this person, and how can I put pressure on this person to get treatment, given that he's quite happy being the way he is, or she's quite happy? But I know, and the family know, if this goes on, the person's going to make a mess of their lives. In a person who has an established, preceding bipolar disorder, and especially if you get to see them before the relapse has become too severe, the person will often retain sufficient insight to say, look, I know what's happening, this is a manic state coming back, it's happened to me before. It's also not by any means unknown for a person with a first presentation, if it's not too severe, they will accept advice from the doctor and from trusted family members that things are not okay and that this is a recognised medical condition called a bipolar disorder and they should seek treatment. And that's, I guess, what Carol's concerned about, and I'm concerned about that too, that possibly, you may be developing a manic condition and this could create problems for you if you start getting involved in business dealings or whatever, when your judgments may be a bit inflated, a bit too overconfident, and you might end up getting into personal difficulties through it. The least restrictive treatment option is, of course, where the person's treated as an outpatient and takes oral medication. And the first line medications nowadays are probably the atypical antipsychotics, possibly benzodiazepines in the early stages to help with sleep, and then we'll generally introduce a mood stabiliser. Of the atypicals, olanzapine and quetiapine are the most favoured because they have sedating effects, and both have relatively recently been approved by the PBS for use in bipolar disorders. The commonest mood stabilisers are lithium and sodium valproate. Other medications are used, but those 4 medications are really the ones with the strongest evidence base in current practice.
That's great, but I take some time away from them and then and I'm perfectly fine, or I'm feeling good and I am feeling good, then I've just wasted an opportunity, haven't I?
But we could,
I can take that on board, but there needs to be some sort of basis on which you can.
Well, as I said,
we can identify that there's something going on.
It is give and take, and Carol's an interested party here too. And I'm sure we can make some agreement, like maybe say 3 days off is a reasonable offer on your part.
I think things are okay.
The next step is voluntary hospitalisation, which is again sometimes achievable, and is probably sometimes achievable in a country hospital setting. It helps by having trained staff available, but the management is not complex really. It's a matter of providing the person with a quiet environment, regular medication such as the olanzapine or quetiapine, maybe with the addition of a benzodiazepine. I tend to use lorazepam, maybe 2 milligrams 3 or 4 times a day. It's quite reasonable doses, again with the objective of quietening the person down as much as possible. From what Carol's told me and from what I've seen today, I do have a concern that what's going on with you may be a mental health problem. You may not be well, what we call a manic state in a bipolar disorder. And I think we need time to just reflect on this and have a look. You're a bit reluctant to accept that. You're saying you want to go on with things. The problem is that as it goes on, particularly if there's more evidence of you being unwell, there is a time when it actually gets taken out of your hands, and doctors use their legal powers to say, sorry Simon, it's not your choice anymore, we're going to take over here.
But what's the basis for doing that when I'm not I'm not unwell?
Well, fair enough question. If I'm right, and you are unwell, I'm not saying necessarily that I'm right, but if I'm right, then I have an obligation as a doctor under the Mental Health Act to protect you from yourself, to protect you from doing things which may end up being harmful to your financial situation or your personal reputation or your marriage because your judgment's impaired by a mental health problem. Beyond voluntary hospitalisation, of course, the next level, if you like, is the use of the Mental Health Act and making a person an involuntary patient. Nowadays in the country, we actually do have more and more authorised units in local hospitals. Like in Western Australia now we have Bunbury, Albany, Kalgoorlie are all capable of having involuntary patients at their regional hospitals. In the future it's going to be Port Hedland and Broome, I believe. And there are mental health teams in those centres too. So getting people into involuntary treatment is not as traumatic and difficult as it used to be. But it's still a big step to take. It means taking away a person's autonomy, and you have to feel confident that's the right thing to do.
And our thanks to Dr. Simon Byrne and that anonymous patient for taking the time to speak with us. Now, before we return to our discussion, a reminder to call in at any time if you have any questions or comments for discussion. The number is 1-800-673-277 or 089 22. Let me start that again. 089 229 5241. It gets a bit confusing, like the whole mental health issue, Olga.
Well, Leighton, after that segment on manic patients, I notice that manic patients really don't like coming off their manic episodes. I guess not least because they're embarrassed about what they might have done or said, and often because they just enjoy being a little bit hypomanic. Can you run them a little bit high?
I think it's always a bit dangerous to do that because it's very hard to predict what the course of each manic episode might be like, if untreated in particular. And whilst generally the course of illness holds true over time, so if a person is, let's say, a bipolar type 2 with mostly depressive episodes and the occasional hypomanic episode, look, they're often not going to present with a hypomania, and they will resolve spontaneously, they won't cause too much damage. But if they're getting to the point where they're presenting for treatment, or other people are presenting them, or they're in the bipolar type 1 with more severe manic episodes, then you're at a time when you really do need to consider a more effective and thorough and longer-lasting preventative treatment, really, because people run a great risk with severe hypomania going into mania. Really, they can be the most destructive of psychotic or mood episodes that you can possibly...
Except that, of course, they always complain that the stuff makes them feel really dead.
Yeah, look, I think that that's where perhaps optimisation of treatment is really important, and not just to think that the manic episode's resolved and therefore we just leave it as it is for now. I mean, certainly you do need to vary your dosages according to serum levels of most of the mood stabilisers between a manic and a euthymic state, because they do change. You need to be cautious about your use of other medications when the person reaches a more normal mood state, because you don't need as much to maintain them in remission as you might do to treat an acute episode. So, for instance, the 30 milligrams of olanzapine as an antipsychotic becomes nothing eventually, or a much lower dose. So you do need to carefully manage through all phases, obviously with the aim of keeping that person in remission for the longest period. And of course, medication won't do that completely, but it will go a long way for most people.
How do you stop them from sliding off into a really deep depression?
Well, that's really difficult. I mean, of course, the bipolar type 2 spend more of their time in depression often, and the bipolar type 1, after a very severe manic episode with psychotic features maybe, often do have a depressive dip before reaching a more euthymic mood state. It is really difficult. It does require a lot of monitoring, particularly for those bipolar type 1s. Not all of them need to have antidepressants added, because that can actually be disastrous in itself, because a certain percentage, probably about 10%, will go back into mania on an antidepressant. But you do need to monitor the severity and the duration of their depressive symptoms at least, and make sure that other things are attended to, optimising their mood stabilisers in particular. OK,
so this is one where we would be talking very carefully with the psychiatrist as a GP.
I suppose so. I wouldn't be rushing medication changes into a lot of people in response to just symptoms, because, I mean, for some people the symptoms are self-limiting, and it is a matter of leaving it simple, and it's a matter of monitoring them in the safest possible way and keeping it simple, and you'll do the right thing by the patient. But in the bipolar 2s, who spend most of the time in depression, they are actually a different kettle of fish. They are often very difficult. They are often very difficult to get into remission. They are from the depression. Obviously, sometimes the combinations of medications are very complex, and in fact, you can actually trip them back into hypomania more often with all the attendant problems. So they take a lot more time.
I guess Moira and I in general practice often also see patients in initial stages of Alzheimer's or other types of dementia, and they're often a bit depressed and a bit disinhibited. They can become intermittently aggressive. How do you sort out, what's the dementia and what's actually something that's a little more treatable?
Well, I think it really very strongly depends on the history, and so the history you obtain from the relatives in particular, or from the GP who's known that person over a long period of time, is extremely important in nailing down what came first, and therefore coming to some sort of more accurate diagnostic formulation. Depressive symptoms are very common in dementia. In fact, they're probably the precursor symptom to the onset of the cognitive decline. So obviously a first depressive episode in middle or later life should be something to be a bit concerned about. And there are a lot of evidence to suggest that many of those people do go on to develop Alzheimer's dementia, so their first symptom is actually a depressive episode.
And if you treated their depression, would that improve their dementing outcome?
No, it doesn't improve their what a pity. I don't think there's much evidence, but I don't think there's any anecdotal or other evidence from experts that makes any difference. But it does decrease the morbidity of the episode, and certainly means that you might follow that person up a little bit more closely, rather than just say, well, your depression's over, get on with your life. They probably do need a little bit more follow-up, with an eye on the possibility of dementia, development of dementia, plus the exclusion of any other organic, if you like, physical disorder that may cause an organic psychiatric syndrome, including depression.
Those late life things are something that are really a red flag for us.
Yeah, I mean, I have seen cases of hypothyroidism, I have seen cases of calcium metabolism disturbance, cases of diabetes, cases of iron deficiency anemia presenting with depressive symptoms. So, I mean, usually there's something atypical about the presentation, or there's some pointers to the physical origin, but they certainly have to be looked for because they sometimes are missed.
Yeah. Now, we've had a case study sent in. It's a 40-year-old woman who's on workers' compensation for chronic pain, and she's known to be selling her MS Contin around the local town, which is the excellent country town rumour network. She's got a chronic disability and having her medication dispensed in a Webster pack, and has refused a pain clinic referral, so probably quite a manipulative patient and certainly someone who's in need of some support. The doctor's question was really to do with managing her access to S8 drugs. Could either or both of you comment on that? Do you want to go?
Yes.
I think the really important thing here is to have a very clear structure. First of all, in terms of your possibilities, in prescribing S8s, you've got two paths you can take. You can go down the pain management path, or you can go down the addiction path. And once you've made your decision as to which one it is, there's a very clear pathway that goes along there. So you've got somebody who's got pain, and people who've got pain, sometimes develop addiction. So the two often do meld a little bit. And what you have to think through is there pain, is there addiction, is there a combination of the both? How much of control do you need? So then, as a GP, you need to make some decisions about what you feel comfortable with. And what you feel comfortable with has to be something where you can say, look, is it a reasonable thing to do? There's a duty of care of wanting to make sure that you treat people with pain. At the same time, you don't want to be taken for a ride and, have this being sold. So generally, you start off by trying to give some control to the person. I'll give you this much. You try and make it safe. You give them a structure if you're going to go down the opiate line. If you go down the opiate pain line, they have to go to the pain clinic. There's no choice. State health says you must. It doesn't matter whether it's workers' comp, whether it's private scripts or whatever. State health does monitor, and sooner or later they will say stop.
Okay, so if that patient is obtaining a large amount of opiates from a large number of different sources, or even from one source but obtaining a lot, that will be monitored regardless of whether it's on a private prescription.
It might take some time, but it will eventually catch up with them. So if you're treating it for pain, you need to do it in a nice structured way. And I actually try to use contracts whenever I can. We don't have time to go through any of them, but we did do up some articles in the CHECK program from November or December last year. That looked at substance abuse, and we used a couple of cases that included, one of them was somebody with back pain. So there was pain, there was addiction, and it was actually about having a structure where you said, okay, if we're going to use opiates, these are the things that you can and can't do, these are the things I'll do for you, and these are the things I expect. And with pain, if people kind of behave in a way that shows that they've got control, you give them the control. If they start to do things that makes you think, well, this is not controlled, like selling drugs, then, you're starting to say, okay, we're going to go more restricted. You're getting, weekly dispensing, daily dispensing. You're going to be observed. If you do certain things, they are criminal activities. Selling drugs is criminal activity. So you actually say, if I hear of this, unfortunately, I do have to report. If I hear in the consultation, that's a different thing to, what you hear on the streets. Okay. So yeah, it comes back to structure, feeling like, it should be, whatever your plan is, you should be able to feel that you can talk with a colleague about it and feel you're not way out on a limb. Because if you do things that are way out on a limb, if that person overdoses and dies, you're really stuck. So if you don't know, don't have somebody else you can talk to about it, give the clinical advisory service a call, which again, I think you'll put up later.
Okay, yes. So we've got a large number of resources that we can attached to our website, including some articles and some advisory services and some telephone numbers for the doctors to have a look at later. Leighton, do you have anything to add to that?
I think, as we were discussing before the program, I suppose it doesn't matter who's paying for the drug, whether it's the pharmaceutical benefit scheme, the patient for a private prescription, or the workers' compensation insurer. It's the Schedule 8 and the regulations that surround the prescription of these sorts of drugs. That is the important thing, and they're not restricted for no reason. It's because of their abuse potential and the risk of misuse in the community. And I suppose in a community when you're starting to hear stories that's suggestive of evidence of misuse, I think as more is suggested, you need to I think be open and honest with this patient. You're obviously not going to be revealing sources of information in such a community, of course, or in any situation perhaps, but I think you have to start from a relationship of honesty and open communication and work from there.
And a good line with that honesty is to actually say, look, you know, there are state health restrictions that are beyond my control. How can I help you to keep them off your back? Is a nice approach for a GP. You know, you're advocating, but you're really helping to keep other people off their back.
Yeah. Moira, you also mentioned overdose, and a lot of the patients do take combined overdoses and arrive in our country emergency department. Does either of you have any hot tips on managing difficult overdoses or super clues as to what the patient might have taken?
If I were in an ED and in a rural hospital, my first thing would be I would call the toxicologist, you know, the toxicology line, because they have 24-hour cover from the toxicologists who deal with that.
And that's the poisons information line number, 131126.
Yeah.
Yeah, I'd be very cautious about attempting to treat anyone myself. Not that I work in emergency at all, but I mean, an overdose of one drug, I mean, there are commonly other drugs involved. You may not get good information that tells you what's been involved. I think probably generally people are more keen to refer rather than to monitor, just in case the situation gets out of hand. But yeah, look, in the country, the poisons information line can give you a lot of, and in the city as well, we use it a lot. For instance, at Greylands Hospital, people are often taking overdoses as inpatients. We tend to refer them quickly because we have the resources, but we do use that line a lot too.
Yeah, I have to say activated charcoal works for just about everything. Fantastic. We might leave it there. Thank you very much for tonight.
Thank you, Bob.
Thank you both, and we will put up those telephone numbers and web addresses a little bit later in the programme. Well, our final segment tonight looks at drug and alcohol use in pregnancy. We spoke to Claire Henderson from the Woman and Newborn Drug and Alcohol Service at King Edward Memorial Hospital about their approach. And we also caught up with Dr. Anne Batu from the Drug and Alcohol Office, who's involved in ongoing research by the Telethon Institute for Child Health Research into alcohol in pregnancy and the rates at which health professionals question pregnant women and provide information about the use of drugs and alcohol.
The Wonders service here at King Edward's is a tertiary multidisciplinary service where women who are misusing drugs or alcohol in pregnancy are referred into. We have a very in-depth assessment of a pregnant woman where we look at all the problems associated with drug and alcohol misuse pregnancy. They include mental well-being, they include welfare and housing, financial problems, they include forensic history, police history, they include partner and family relationships, they include the medical history as well, which is really important because these pregnancies are high risk and women are often very unwell and can have problems around Hep C and heart problems, etc. And we also have good midwifery care throughout their pregnancy. So we invite women in an open way to attend for antenatal care as often as they wish. So have you been using drugs or alcohol in your pregnancy?
Most nights, just a few glasses of wine.
Okay. And has the risks of those been explained to you by anybody? Okay. Well, we have a really good leaflet that we give out to pregnant mums that explains...
Probably less than about 30% of health professionals actually raise the issue among women when they are pregnant. Our research also shows that these women really expect to be asked, that they expect a lot from their health professionals, and they expect their health professionals to be very well informed, to have a very sound knowledge of drugs and the effects of drugs on their infants, and that they value their advice. Many of these pregnancies are unplanned, and the women don't realise they're pregnant until perhaps well into the first trimester. For instance, if somebody is just using a very small amount of drugs very early, before they even know they are pregnant, the mothers want to know if this is going to affect their baby. And a lot of them get very concerned about that, and they expect their GP to have that sort of information at his fingertips.
Now, the main focus obviously is around fetal alcohol syndrome. Pregnancy and drug and alcohol misuse is multifaceted. It isn't just about one problem. So it's really important that we have access to very, very good support services for these women, because if we don't solve all of the problems, we're not going to solve any of the problems.
These mothers are a special population, and they certainly need follow-up care and evidence-based follow-up care to get the best results for their infants and their pregnancies.
All of the research points towards this model of care that shows that in order to be able to get an effective, good outcome for the mum and the baby, and that's them both, not just the baby, that we need to look at the women holistically and care for them in every way. There's a lot of other problems that we cover in pregnancy that we do an assessment for. One is domestic violence, so we do an in-depth tool to check that women are safe in pregnancy, because we are aware that due to research that women are more likely to be victims of domestic violence in pregnancy, especially when there's substance use related problems there. We also look at bloodborne viruses, and a lot of our women are infected with hepatitis C.
We talk about the mother, we talk about the baby, we talk about all the physical type things that a GP would normally do, and that is the full assessment of the quantity and frequency and the number of categories of different drug use, partners drug used. If they're using illicit drugs and if they're injecting drug users, they need to be screened for bloodborne viruses.
So we will offer all women a hepatitis C RNA test as opposed to a hepatitis C antibody test, and that way we can look to see if women are infected and if the virus is live at that time. We also offer women folate in pregnancy because a lot of these women are anemic. We also offer all women a sexually transmitted infection full screen during pregnancy and a pap smear.
Many of them will have drug-using partners. And although most women really want to do the best for their babies, they find it very difficult if their partners are using as well. So for a GP to be dealing just with a mother, the potential mother, basically it really should extend to the rest of the family, perhaps at least the partner as well.
We offer women a full assessment around their financial history. Is there any support we can give them? Are they illiterate? Can they not fill in forms? Are they behind with forms? That kind of thing. Very basic stuff. So those are the types of assessment and screening that we offer for all pregnant women, and they really are achievable for every health professional. You don't have to have any specialist services for those. That's very basic stuff. So we would recommend that a minimum of STI screening, pap smear, bloodborne virus screening and domestic violence screening are carried out with all pregnant women.
And the alcohol and drug use needs to be incorporated in a non-judgmental way within the whole full assessment in a comprehensive manner.
In pregnancy, we do what's called an Edinburgh Depression Score, right, which is a chart where we look at how your mood is, and it's about how you've been feeling in the last week. Okay. Sure. When we pick up a specific problem, we'll refer appropriately. The women are informed about this referral and they're informed why we're assessing. So if a woman has an underlying mental health problem, whether that be before the drug and alcohol misuse or after the drug and alcohol misuse, we will refer that woman into our psychological department here at King Edward's. We have a psychiatrist who is linked to the Wonders team who works specifically with our women, and he's actually kept very busy. So he will see all of the women and do an assessment when we've picked up a problem. And then from there, the women are either given therapeutic intervention through King Edward's, or the psychiatrist will be a liaison person with the services that the women are already involved in.
Okay.
You know, I know that you are struggling with some things, and I'm not belittling, I don't think a tool's everything, but, you know, all in all, your mood seems to be okay, you know. You seem to be coping with...
One of the reasons we think that health professionals do not routinely raise the issue is that they feel poorly prepared and under-supported for it, and definitely under-resourced about what to do with a woman, how to plan her care. Now, we developed a booklet which actually looks at how do you do it, how do you raise the issue, what is the role of the health professional, How do you ask about it and their partners? And we talk about screening tools. When should they screen? What should they screen for? Now, we've also included referral sources where they can get additional help, both for themselves and for the women. Wallet cards, fact sheets to be handed out to the mother. And these were developed in response to what the GPs were requesting. If they can have something that can be handed out for the woman to take away, it makes a lot of difference.
There are national clinical guidelines that all professionals have access to, how to care for women who are misusing drugs and alcohol in pregnancy, and they're an excellent resource for all health professionals.
Now this is for a range of drugs, heroin, cocaine, amphetamines, benzodiazepine, and also, particularly for GPs, for management of the drugs which are used to treat opioid addiction, such as methadone and buprenorphine.
As a tertiary centre, we're here for remote GPs who, they don't have a multidisciplinary wraparound service around them to support them. However, they definitely have links with King Edward's, so we're here to support. So any GPs can get in touch with us if they need support around caring for a pregnant woman who's misusing substances.
The resources are there to ease your role, basically, and to enable you to provide information to the mother so that she can take a part in the decisions during her pregnancy.
And our thanks to Claire Henderson and Professor Anne Batu. Now, if you want to access any of the resources mentioned earlier, links will be provided on the Rural Health West website. Now, speaking of resources, there's a few other avenues of information and support in the areas of mental health and drug and alcohol use that you're probably aware of, but still worth mentioning. The Alcohol and Other Drugs Clinical Advisory Service is a 24-hour statewide telephone service for GPs or other health professionals seeking advice about patient management from a specialist. You can call them on 08 9224 95042 or toll free on 1800 688 842. And then the Alcohol Pharmacotherapies Callback Service provides a referral service for GPs. Within 48 hours of referral, an alcohol and drug information service counsellor will call your patient back at a time they prefer, negotiate a comprehensive treatment plan with them, and fax you a summary of the first contact and keep you informed of outcomes. The service can be part of a Medicare GP management plan. An information sheet for GPs and a GP referral package is available for download via the Drug and Alcohol Office website at www.dao.health.wa.gov.au. You know the drill. The Office of Mental Health has a searchable online database of mental health services in your region. If you're not already familiar with it, it's well worth a look. Go to the Office of Mental Health website at www.mentalhealth.wa.gov.au and click on Mental Health Services. The Western Australian Association of Mental Health also has a very comprehensive list of links and resources related to mental health assessment and referral. It can be found at www.wamh.org.au. And once again, all these links will be posted on the Rural Health West website, so if you're too slow with the pen or the tip of the pencil broke, don't fret. Now, any final thoughts from our panel tonight? Moira, last words of wisdom for our docs?
Last words, I think the most important thing is when you're dealing with people with pain, addiction type issues, have a structure, talk with someone else about it, don't be out on your own.
All right, Leighton?
I think if patients are presenting with depression, or if depression is hard to treat, I think always never forget to ask about hypomanic or manic symptoms, because the approach to treatment is very different, can make all the difference to that person's long-term well-being.
Any final words from you, Dr. Ward? See you at the conference?
See you at the conference.
That's it for this evening. Don't forget, if there's any part of this program that you'd like to review at a later time, a delayed transmission of the Rural Doctors program will be available via internet web streaming next week. Now, this service is accessible through the Rural Health West website at www.ruralhealthwest.com.au. Now, do note that the internet transmissions are password protected, so if you haven't already, you'll need to register by contacting Rural Health West. And also be warned that this service works best for those with high-speed broadband, if in fact that exists. Now, because of some changes to both the evaluation requirements from RACGP and ongoing changes to our website, we've been having some trouble getting the attendance and evaluation forms to you. We're hoping this will soon be resolved, and the forms should be available on the website soon. We'll be back on the 1st of April with a program for you focusing on haematology. We look forward to your company then. Thanks again to our studio panel, Dr. Olga Wood, Associate Professor Moira Sim and Dr. Leighton Chadwick, and to everybody else involved in the program. But most importantly, thanks to you for taking the time to join us. From Jerry Gannon, good night.